we're going to go over a brief shoulder evaluation, not comprehensive, but we'll go over all the essential tests that you may need in your practice. First thing is inspection. What we're looking for, is there any sign of swelling, especially over the subacromial bursal area? Is there any deformity, especially in the clavicle if there's been trauma involved? Is there any separation of the AC joint where that clavicle is popping up? Or is there possibly a glenohumeral dislocation? That one would be pretty obvious. The other one is if the patient has pain in their biceps, is there a big bump where the long head of the biceps used to be, and now we have a Popeye deformity with a bump in their arm? One of the things that we want to be particularly cognizant of is there muscle wasting? Is the supraspinatus intact? Is there good bulk through this area? Is the infraspinatus intact in that area? If we see that muscle is wasting, then we're suspicious of something going on with the nerves to that area or something within the muscle. The other thing that we'll look at is there scapular winging? We'd like to see that his shoulder blade is nice and flat against the thorax. If we see prominence of that inferior angle, that tells us that this patient probably has scapular dyskinesis and is probably the reason that they're in your clinic in the first place. The other thing that we'll do is a range of motion assessment. We'll do that active, passive, and resisted. The motions that we're especially looking for is elevated abduction. So having that patient just bring their arm up, they should get to about 180 degrees. What we're really wanting to pay attention for is there a painful arc between 90 and 120? That tells us there's probably impingement. Patients with impingement have pain in that range, and up above that range, the pain tends to go away. We'll also look at elevated forward flexion, and that should be up to 180 degrees as well. We'll look for internal and external rotation. So external rotation is pretty simple. What's happening here? Internal rotation, we can measure that in a horizontal plane, and we see some tightness here. But what's even easier is to measure that by having the patient bring their hand behind their back and touch as high as they can. Don't forget that the dominant arm, Dr. Steele's right arm, is always going to be less flexible than the non-dominant arm. But if there's more than a 10-degree deficit of internal rotation from one side to the other, that's the definition of GIRD, glenohumeral internal rotation deficit. We can also measure horizontal abduction and adduction, extension of the arm, but in reality, those first four measurements are the things that we're really looking for. Next, we're going to palpate the area. We're looking for any swelling, especially over that subacromial bursa. Is there tenderness of the SC joint or tenderness of the AC joint? If that joint is traumatic, it could be dislocated. If there is tenderness over an older person's AC joint, it could be osteoarthritic. Most clavicle fractures are going to be very tender. Most of them are going to happen. 80% are going to be happening in the mid shaft of the clavicle. So that's where we're looking there. We'll also palpate the bicipital groove for primary biceps tendinopathy. That happens in only 10% of all biceps cases. Most biceps tendinopathies happen right here, where everything else in the shoulder happens. That's just beneath the acromion in this subacromial space. That's where the biceps tendon is coming up, the supraspinatus tendon is coming in, the subacromial bursal lives, and when the patient raises their arm, they're pinching all of that stuff. So most patients are going to have tenderness in this area. 2/3 of our shoulder pain patients have some degree of impingement or a problem with the rotator cuff. So that's going to be the number one area that we're looking for tenderness. The other thing that we'll look for is there any tenderness over the coracoid? Remember, that's where the pec minor and the short head of the biceps attach, and oftentimes those muscles are tight. That's what's promoting that scapular dyskinesis in the first place. The next thing that we'll look for is muscle wasting. Is there any wasting of the deltoid? Is there any, and that could be coming from an axillary neuropathy, or is there any wasting of either the infraspinatus or the supraspinatus or the infraspinatus? That could be a suprascapular neuropathy. Those are things that mimic rotator cuff problems. So if we see that one side has a shrunken muscle compared to the other, we want to be suspicious of those problems. The other thing that we'll look for is trigger point activity, especially in the four rotator cuff muscles. We're always going to see tightness in the cervical muscles, the trapezius and the levator. But is there trigger point activity or tenderness in that supraspinatus muscle or in the infraspinatus muscle? This is one that's present in almost everybody, as well as the teres. The hidden muscle of the shoulder that you and I need to have our hands on a regular basis is the subscapularis. Reaching into that patient's axilla and getting underneath the scapula to hit the subscapularis. That's the muscle that often has trigger points that are hidden, and if we don't address, that patient continues to have issues. When it comes to joint palpation, we'll check out the sternoclavicular joint. That joint is tough to shear or to move. Really, the only way we can do that is by palpating and having that patient abduct and adduct their arm, horizontally adduct and abduct, forward flexion of their arm, and we're saying what's the motion of this SC joint compared to the other SC joint. The AC joint is a little bit easier to move. We can do some shearing of that joint. We can also do an A to P shear, which is Paxinos test, to say how does the AC joint shear from one side versus the other. And then of course we want to check out the cervical spine and the upper thoracic area with motion palpation to make sure that all of those joints are functioning. Within our shoulder patients, a lot of that's not the case. The one joint that we definitely don't want to overlook is the scapulothoracic joint. When the patient abducts their arm, what should happen is that for every 2 degrees of glenohumeral movement, there's 1 degree of scapular movement. So as he's coming up, I should see this happening. And if that's not happening, we know that we have scapular dyskinesis. The next thing we'll look at is the orthopedic assessment, and that's going to be specific to the differential diagnosis. Since 2/3 of all diagnoses in the shoulder come from the rotator cuff, let's start there. We'll look for impingement. The 3 classic signs of impingement are number 1, empty can, patient bringing their arm up as though they've emptied a can, me pushing down. If there's pain, we have some suspicion of impingement. The next one is Neer's test. That's me taking the patient's arm through this range of forward flexion and sometimes applying a little bit of overpressure to the acromion and saying, is there pain underneath there? And number 3 is Hawkins-Kennedy. Think of this one as holding your arm out, a hawk lands on it and pushes down. That test is another classic sign of impingement. 3 tests that I really like for the rotator cuff are number 1, the external rotation lag sign. That's me taking the patient's arm back into external rotation. I'm holding it there for a second, and now when I let go, if he's able to hold it there, that gives us an indication there's probably a competent supraspinatus. If he dives down into in a position of protecting the shoulder, now we have a high suspicion for the potential of a supraspinatus tear. The next test would be the internal rotation lag sign. In this case, the patient is basically doing a scapular liftoff. I'm pulling back, and if he's able to hold it there when I let go, that tells us there's probably a competent subscapularis muscle. And then the third test that I really like is the dime test. The way the dime test works is the patient brings their arm up first laterally, and I push it back down as he gently resists. We do that again in the scapular plane, same thing coming up, and I push it back down. That's a test that is, again, very highly sensitive and specific for a rotator cuff tendinopathy or a rotator cuff tear. The next thing that we'll look at, don't forget that the biceps, the long head of the biceps and the supraspinatus are both right underneath this acromion. So if one's pinched, both are usually pinched. The way that we'll test for a biceps is a couple of things. Number 1, we can do a bear hug test. Patient brings their arm up onto their chest and I attempt to pull it off. If there's an incompetent biceps, that's going to hurt. Number 2 is Speed's test, taking your arm out, thumb up, and I'm pushing down. If that doesn't hurt, the biceps is probably okay. And finally, the uppercut test, where he's simply imagining that he's punching someone who's standing in front of him with an uppercut. If those 3 tests are negative, we probably don't have a lot of biceps involvement. For the AC joint, a couple of simple tests. Number 1, it's going to be tender over the AC joint. And if it is tender, have that patient bring their arm across their body for cross-body adduction. If that intensifies the pain, it increases our suspicion of an AC joint involvement. The other test that we can use is Paxinos, simply compressing the clavicle up into the trapezius, and if there's an increase in pain, that gives us a good suspicion that the AC joint is involved. To test the labrum, that oftentimes where that biceps comes up attaches onto the labrum, sometimes it can peel that off into a slap or a labral tear. A couple of good tests for that is number 1, the biceps load test, simply asking a question and then saying with your arm bent a little bit, saying let's arm wrestle. And as we're arm wrestling, a slap will usually hurt. If it doesn't hurt there, ask a taller question and push again because it usually will hurt in that case. O'Brien's test is simply having that patient take their arm out, and now I'm going to push down first in pronation and finally in supination. If the pain eases when that's performed in supination, it gives us an indication there's probably some slap involvement there. And finally, crank test, this patient is going to take his arm up. I'm going to actually compress the arm and then rotate the arm back and forth, and we're looking for either some clunking or discomfort along the way. The last thing that we're going to look for is the strength of each of the rotator cuff muscles. So we're going to test the supraspinatus, which we've already done with an empty can test. We're going to test the infraspinatus and the teres by attempting external rotation to the area, so bringing your arm out in a hornblower sign. And then we're going to do a test of the subscapularis, either with a belly press test, pulling it off there, a bear hug test, pulling it off there, or most classically, the scapular lift-off test, which is going to produce pain if the patient has some subscapularis involvement. Now, the other thing that we don't want to miss for a shoulder evaluation is to look at the function of the scapula. Remember, that patient is going to have some pain usually through that painful arc, 90 to 120 degrees. So when they raise their arm and they say, ouch, what we do is two different things. Number one, we try to do it again by helping them move their scapula. So in this case, as he's raising his arm, I'm rocking his scapula for him. If that decreases the pain, it tells us this patient could benefit from scapular mobility. The next test that we'll do is if this patient has winging of the scapula, I'm going to hold his angle of the scapula against his thorax as he comes up and he abducts once again. And if that retraction of me forcing the angle of the scapula against the thorax relieves the pain, that tells us that patient probably needs some stability. The great thing about this test is you can instantly turn it into a tool to educate the patient to do their exercises at home. If that helps, have the patient gently retract their scapula, lift their arm again, and they say, you know what, it doesn't hurt. Then you have the teaching opportunity to let them know that as long as you can keep these muscles tight and keep your scapula tucked into your back pocket, you'll probably have a whole lot less shoulder pain. The other thing that we'll want to look for is there any evidence of upper cross syndrome? Does this patient have a forward head, forward shoulder posture, or weakness of the deep neck flexors? And don't forget the cervical evaluation, that almost half of all shoulder pain comes from an asymptomatic cervical spine, and up to 1/3 of those patients who have shoulder pain have a compressed nerve root in the cervical spine. So we'll do our standard neurologic evaluation of the dermatomes, the myophotomes, and the reflexes. We'll also do Sperling's test, some lateral foraminal compression of the area to say, does that increase the patient's discomfort? We can do a nerve tension maneuver, which is basically a straight leg raise of the upper extremity by laterally flexing his head away, abducting his arm, and say, does that cause any nerve stretch or pain? And one of my favorite tests, and one of the easiest, is simply the arm squeeze. Taking that patient's arm, squeezing the arm, and if there's an increase in discomfort, that did nothing to the rotator cuff or the biceps, but it did cause some irritation to that pre-irritated nerve running into the arm. I hope that this has helped with your shoulder evaluation. If you'd like to dive deeper into any of those tests, check out the ChiroUp Clinical Skills tab. We've got all the detailed videos for your convenience. Thanks for watching.